Distinguished guests, good afternoon, and welcome to the session Making the Business Case for Investing in Infection Prevention and Control in Healthcare. For those who don't know me, my name is Paul Zubail. I'm the Deputy Director General for the European International Health Politics at the Federal Ministry of Health here in Berlin. And it's a true honor to welcome you to today's session at the World Health Summit 2022, which is organized jointly with the World Health Organization. The Federal Ministry of Health in Germany is the leading partner of the WHS and a long-standing supporter of this forum, promoting collaboration and truly foster an open dialogue. The aim of this session today is to discuss the importance of infection prevention and control and generate new insights for policymaking and for concrete actions at the national, subnational, and healthcare facility level. To this end, the discussion today will first start with a short situation analysis in G7 countries and globally, and then make a deep dive into demonstrating the business case for investing in IPC and WASH and health facilities. In the second part of the sessions, we will focus about lessons learned from implementation of IPC programs. Ladies and gentlemen, the global report of WHO and OECD indicates healthcare associated infections and antimicrobial resistance affect hundreds of millions of people every year worldwide. We note with deep concern that delayed diagnosis and management of sepsis and ineffective or unavailable antibiotic treatment leading to sepsis is killing an estimated 11 million people per year globally. While the healthcare-associated infections cause more harm to patients and health workers in low and middle income countries, they are also a problem in the global north. If you look at the figures, 7 in 100 persons admitted to acute care hospitals in high-income countries develop a healthcare-associated infection. 8.9 million were reported in 2018 among EU and EAA members. So I think with these numbers in mind, we can truly say it is a global problem. Both the social implications and the economic burden of such infections are not to be underestimated. Numbers are high, and global health organizations have long articulated the scaling up of IPC strategy is indeed an excellent investment. Many infections could be avoided by implementing simple measures. Therefore, under the German G7 presidency this year, the health ministers have committed to strengthening infection prevention and control programs across the One Health spectrum, in particular for healthcare facilities. The G7 health ministers requested WHO and OECD to prepare a report on IPC and present it at the World Health Summit here in Berlin. The G7 have also committed to supporting other countries to strengthen IPC capacity, obviously, in healthcare facilities. The report aims to provide a global overview on the problem of infections and AMR acquired in healthcare, and it presents evidence of the effectiveness and cost effectiveness of IPC interventions. This is to set the stage on what we will be discussing with this distinguished panel today. Before we do this, we have 3 presentations, and now I have a true honor to welcome our first speaker from WHO. Her name is Professor Benedetta Allegranzi. She's the technical lead for the Infection Prevention and Control Hub and Task Force at the WHO HQ, and she will give us a global situation analysis, Benedetta, on IPC program in health with a focus on G7. Benedetta, the floor is yours. Thank you very much.
Thank you very much, Mr. Zubail, for your nice introduction and also for facilitating my work because you made a very insightful introduction to this topic as a global issue, a global health matter. It was also clarified by previous sessions on AMR in particular. And in fact, it has already been said that hundreds of millions of patients every year are affected by healthcare-associated infections. And in the map that you see, which is included in the global report on infection prevention and control that WHO published, you can see some data from high income or middle income countries, which tell us that really the prevalence is nowadays lower than when we estimated it to be 7% in high income countries, but in low middle income countries, it was exactly the double or more. 15% of patients acquired a healthcare associated infection. So nowadays in Europe, it's around 6.5%. In the US, it's around 3.2%. And so on. And it's a global problem also because most of these infections are due to antimicrobial resistant pathogens. We learned recently that there are more than 5 million deaths every year due to AMR, and those pathogens which cause this are mostly 5 out of 6 most frequent pathogens are mostly transmitted in healthcare. So it's a certain evidence-based principle that infection prevention and control protects patients, health workers, and visitors from harm to healthcare-associated infections, which are avoidable, including those infections due to emerging and pandemic-prone and antimicrobial resistant pathogens. And what we know for sure, based upon a number of systematic reviews of the literature, which are summarized in the global report, and also in some of the evidence that we published to support our work on interventions of IPC interventions, we know for sure that from 35 to 70% of those infections are avoidable, are preventable. And building upon this evidence, WHO, with the important scientific organizations and stakeholders, a few years ago developed evidence-based guidelines to indicate what are the core components for effective infection prevention and control programs. These are 8 core components. Today, we don't have much time to go into the details of these core components, but I'll mention some of them when I talk about the situation worldwide and also the situation, especially in G7 countries. Recognizing that implementing these 8 core components at the national and at the facility level proves to be ambitious and challenging sometimes for some countries, what we elaborated was also to identify what are the minimum requirements for effective IPC programs derived from these comprehensive recommendations on the core components for IPC programs. And so we proposed a stepwise approach to, first of all, as a starting point, have in place the minimum requirements for infection prevention and control, and progressively achieve all full core components by any country. And just to give you an idea, I don't want you to read this entire slide, of course. Just to give you an idea, these minimum requirements are really basic requirements, like having a fully trained and dedicated focal point at the national level and at the facility level for infection prevention and control. And for example, we learned how essential this is, and possibly also have full teams during COVID-19 pandemic. In the heights of the pandemic, really all countries rushed to make sure that they had this focal point at least in place. Another basic requirement is to have IPC guidelines, or to have all frontline healthcare workers trained in IPC measures and practices, such as knowing how to appropriately wear personal protective equipment, for example. So these are very basic principles. The good news nowadays is that infection prevention and control has now gained attention within the political agendas and at the global level. This has been demonstrated firstly during the last World Health Assembly, when all ministries of health of member states decided to adopt a resolution on infection prevention and control. And this resolution is heavily based on these core components of which you see the image again on this slide. And this is also what was highlighted recently, as Mr. Zubel highlighted, by the G7 countries in a recent communique, which noted that this topic is worth of more attention, and requested the development and publication of an additional report in addition to the global one by WHO, to focus on the global level, but also the G7 countries, which are all high-income countries, as you certainly know. Which the resolution at the World Health Assembly this year also indicated that it is important to develop a global strategy for infection prevention and control, a global action plan, and a monitoring framework to hold countries accountable for implementing the minimum requirements and the core components. So all of this is explained in this report that was published first globally, and secondly, today is the launch date of this report focusing on the G7 countries. And this report provides an overview of the global and also G7 countries' situation, presents evidence on effectiveness and cost effectiveness of IPC interventions, and also indicates some strategic directions to G7 countries primarily. And surprisingly, there are directions to give to these countries which are very advanced, as you can imagine. So on a global level, there are many data that you can find in the WHO global report, and I don't have time to go into the details. But basically, in the latest assessment by the AMR tripartite, which has a very detailed database, which also focuses on infection prevention and control programs in human health. According to this database, recently, between 2020 and 2021, there were still 11% of countries worldwide which didn't have any national program or national plan for infection prevention and control. 32% of countries had this plan or program, but only implemented in selected healthcare facilities on the national territory. And finally, only 35% of countries actually reported to have a functional active IPC program, which is nationwide implemented, and also it is monitored in some of them to evaluate its effectiveness and impact. So regarding G7 countries, we looked at their performance according to the same indicator that it's coming from the tripartite database, and this is what you see here. And we also looked at their performance over time. So we can say that all G7 countries have a national IPC program or an operational plan. 5 G7 countries over the last year measured achieved the highest level of progress according to that indicator, which I have already explained what it means, having a nationwide implemented program which is also monitored. And 2 of them reported, however, lower levels of progress. Looking now at the minimum requirements, so those minimum requirements, which are 25 overall at the national level to reflect effective IPC programs at the minimum level of progress. So overall, we conducted last year a global survey, which led us to the bad news that 4% of countries only have all minimum requirements in place. And unfortunately, none of them is a low or lower middle income country. Most of them are high income countries. Regarding the G7 countries, we can see that none of them met all minimum requirements. Some of them are just missing one or two, but none of them met all of them. But 5 out of 7 met more than 80% of the minimum requirements. This is a comparison with other high-income countries, and you can see that in general, G7 countries perform a little less well on healthcare-associated infection surveillance, multimodal strategies, and monitoring, evaluation and feedback of IPC indicators. The most frequently met minimum requirements by G7 countries were IPC program with its requirements and also IPC guidelines, but none of them met all minimum requirements for IPC training and education, and you can see that from the graph. And this was actually the most defective minimum requirement core component. And the other gaps in G7 countries were seen in strategic plans and systems for monitoring IPC indicators, or, for example, the requirement of having hand hygiene compliance among health workers measured at the national level. So what is the future and what are the directions to improve? I will make a very brief summary, but I encourage you to look at these recommendations more into the details through the report that we launched today. So overall, we reflected on where we are as a global community after 3 years of COVID-19 pandemic and what it meant for the healthcare system. Through these various assessments, surveys that WHO and others conducted, we could appreciate that there are many gaps, but also there have been progresses in countries during the pandemic. And as I said, you can find this information very detailed in the global report. So now what is essential is to focus on sustainability of this progress and also bridging some quite significant gaps that we are still facing, especially in low middle income countries. There is a need for long-term investments which overcome the acute bridges that were made during the pandemic. And also, at the same time, especially at the healthcare facility level, we need to continue to maintain the high level of readiness that is required because we are still during a pandemic. And there can always be surges coming up due to variants or other issues. We also need to focus now on reducing the burden, the endemic burden, the everyday harm caused to patients and health workers due to everyday healthcare-associated infection and AMR transmission in healthcare. And finally, really strengthen IPC in the context of resilient health systems, including in primary care settings, which require more attention in different ways, including for IPC. For the G7 countries, we have 4 important recommendations based on the gaps that we could find. One is really to further strengthen IPC programs based on their own specific gaps, and in particular, also pay attention to infrastructure, because even in high-income countries, we learned that we don't have enough single bedrooms. We don't have enough good ventilation systems, for example, in healthcare facilities. So there are improvements to be made. We also have to improve training and education, of course, and strengthen monitoring surveillance because it's still an effective area, and use data for action. Use your own data to implement interventions. So the next slide are more details on these 4 elements, without forgetting that G7 countries have a role in supporting countries with lower resources and also in financing and conducting research. I'm pleased today to also launch a new webpage of the WHO website, where we tell country stories about implementing successful IPC programs. And the first story is about the IPC program in Germany, which is particularly strong. And with this, I would like to thank you all and thank the German presidency of the G7.
Well, thank you, Benedetta, for this excellent situation analysis and for the discussion that we will have later. And this will form the basis for really engaging panel discussion later. But now let me introduce Michele Cecchini. He's the head of public healthcare at OECD, and he will give us some insights on the business cases for IPC. Michele, pleased to have you here. The floor is yours. Thank you.
Thank you very much, Chair. Good afternoon, everyone. Hello, everyone. It's a real pleasure to be here. It has been a real pleasure to work together with colleagues at WHO and work towards a joint aim to support the German presidency of the G7, as well as G7 countries and beyond the G7 countries at the global level. In the next few minutes, the objective of my talk is to make together the business case for infection prevention and control, which is one of the components of this joint brief for G7 countries. Now, the focus of our report is on infection prevention and control, which is a great intervention for all types of infection, particularly hospital-acquired infection, whether they are susceptible or resistant. But in the context of our continuous fight against antimicrobial resistance, infection prevention and control can give us an extra boost in buying time until we have new antibiotics on the market. These are some analyses we carried out on the projected rate of antimicrobial resistance in G7 countries and EU27 member states. By 2030, the average resistant proportions are projected to approximate 20% in this group of countries. Now, compared to other countries, countries at different level of income, certainly these countries currently have a lower burden of AMR, but this burden is projected to increase if we don't do something quickly now. None of the G7 and the EU27 countries are projected to achieve a reduction in resistant proportion in the 8 backdrop combination that we have taken into account. We see some progress in certain areas, but certainly there is no single country that can say we are on the good path to tackle antimicrobial resistance today. What is even more worrying is that the resistance to second-line antibiotics, which are our backup option when first-line antibiotics do not work, is projected to increase more than for the first line. In particular, we projected that the resistance for this group of bacteria, a backdrop combination, will nearly double by 2030 compared to 2005. And this has a cost. This is a cost that healthcare systems pay every single day. Between 2015 and 2050, AMR will cost $4 billion purchasing power parity per year to the healthcare system of G7 countries if the projections that we have looked at together continue on the path. This is because patients with resistant infection need longer hospitalization, require more intense treatment. G7 countries are expected to spend on AMR nearly 2.5 times the health expenditure that they had, for example, in 2015 on HIV and AIDS, which are much more prominent and much more talked about diseases compared certainly to AMR. The big issue as well is that unless effective action is quickly put in place, this cost will continue increasing in the future. Our contribution to this brief was to look at two very typical IPC interventions on which countries can do better. Our interventions are enhanced hand hygiene and enhanced environmental hygiene, which are part of the minimum requirements and the core components that WHO recommend as part of a strong infection prevention and control strategy. We looked at the impact of this intervention, not just on resistant infection, but on all the infections. We saw that IPC would alleviate the burden on hospital resources by preventing additional days spent in hospital. Specifically, enhancing hand hygiene to meet gold standard and best practice would avoid across these G7 countries more than 220,000 days hospital nights per year. These are only patients that are in a hospital because of a resistant infection. Perhaps they were in a hospital for other reasons, but these are the extra days spent in hospital due to a resistant infection. This is a big number. To give you an idea of how much more than 200,000 nights per year of hospital, it's similar to occupying every single day of the year all the hospital beds available in a country such as New Zealand or Latvia. IPC policies can help us prevent all this. IPC policies, such as enhancing hand hygiene and environmental hygiene, we calculated are an excellent investment for G7 countries. Investing just a few dollars more per capita per year would produce significant savings in healthcare expenditure with an excellent return on investment. We calculated that for each euro spent on upscaling this type of intervention, we would have a return on investment of 11 gain for one single dollar spent on this intervention across G7 countries, and we would avoid tens of thousands of deaths. 30,000 of deaths in the case of infection enhancing hand hygiene in these countries. Savings would derive by decreasing number of time spent in hospital and a lower need for intensive care. To sum up, investment in enhanced hand hygiene and environmental hygiene are best buys. At the OECD, we co-developed with countries a set of criteria to decide what is a best practice, what is a best buy for the country. The set of criteria is based on 6 dimensions. The practice would improve population health and lives. It would provide good return on investment. It decreases health inequalities. It's affordable to implement. It's politically feasible. It's scalable and transferable across countries. As you can see, all these criteria are met by this intervention. We would avoid tens of thousands of deaths. We would have a return on investment of up to $11 for each US dollar invested. Populations such as children, elderly, and fragile persons, we know that are a higher risk for resistant infection and for infection. And this would be the person that would be benefit most from this type of intervention. This is affordable to implement. Our business case calculates that across G7 countries, it would cost between tens of cents for up to a few dollars to implement per year, which is a figure that is highly affordable for these countries. And clearly, we calculated in a different context would be affordable for many countries, even a lower level of income. There is broad consensus of this intervention. These are part of the core components of the WHO. Finally, these are interventions that we know are scalable and transferable across countries. As we are talking about AMR, and that's something that we mentioned in our joint brief, but it's not something that we developed so far, but I think it's very important to mention. We believe that tackling AMR requires a multi-pronged approach, of which IPC is one of the three fundamental pillars. We need to invest in infection prevention and control. This should go hand in hand with promoting prudent use of antibiotics. IPC help us promoting prudent use of antibiotics. If a person in a hospital, in the community doesn't develop an infection, this person will not need an antibiotic, and we can avoid waste, overproduction of antibiotics, and use the antibiotics when they are needed. Finally, very important, investing in research and development for new antibiotics, vaccines, and diagnostics. And I think perhaps there will be the opportunity to discuss more about this also in the panel. I stop here. I thank you very much for your attention. I invite you to have a look at our joint brief, OECD WHO brief on infection prevention and control. You can download it from the website. Thank you very much.
Well, thank you, Michele, for this excellent presentation. And I think we now have a good wealth of information that will, in fact, fuel a candid, critical, and in-depth discussion that we can have today. Having said this, I would like to give a warm welcome to the chair of the panel, Dr. Rudy Eggers. He's the Director of Integrated Health Services at the WHO, and he will facilitate today's discussion. Thank you very much. Warm welcome to Rudy. Thank you.
So good afternoon to everybody and welcome to the session. We'll have a panel discussion and also questions from the audience, so open discussion on the topic. As was said, my name is Rudy Eggers, Director of Integrated Health Services in WHO. So central to every healthcare is the encounter between a person seeking healthcare and a person providing that healthcare. And important to that encounter is, of course, quality, safety, and the integration of those services. And in the broader sense, IPC is right in the center of that. It's about preventing any and all healthcare associated infections. And let's think about that in the broadest sense. So that includes that healthcare that's provided under the tree, where hand washing is an important thing, right up to the wound infection in a critical care unit. And I think the data that was shown by Michele a minute ago is just amazing in terms of just showing a basic intervention such as hand washing making such a huge effect. Today we've got three distinguished panelists, and let me introduce them to you before we go to the questions. We have Dr. Francesca Colombo, who's the head of the health division of the OECD. Welcome to our session. We've got Professor Petra Gastmeier, the director of the Institute for Hygiene and Environmental Medicine at the Charité, the University Medicine Hospital in Berlin. Welcome. And then online, we've got Professor Céline Pulcini, who's the director and coordinator of the French AMR National Action Plan in the French Ministry of Health, and the chair of the European Society for Clinical Microbiology and Infectious Diseases Study Group for Antimicrobial Stewardship. Welcome to all three of you. Dr. Colombo, let me start with you with the first question. So how can countries create the enabling environment necessary to reduce the healthcare associated infection? For instance, patient safety. Over to you.
A small question, but I'm glad that you framed this in terms of patient safety, because I think there are obviously many other issues that relate to patient safety, but we're talking pretty much about the same sort of approaches, the same instruments, the same way of doing to address the issues here. And I think there are maybe 3 points that I wanted to make. Also in reflection to what we heard from the presentation. The first thing is related to how frequently we have issues related to hospital-acquired infections, and also how frequently we have patient safety issues that happen, which are preventable and which really cause a lot of harm in terms of mortality and mobility, and that we could be doing something about that. So there are two frequent times did these things happen, with a cost for the patients, the people involved themselves, for the healthcare system in terms of additional healthcare expenditure, and more broadly for the sustainability. And we have made a report in the past that look also issues of waste in health system, and those things which are preventable are clearly clear aspects of waste that we should do something about that. So that's my first message, too frequently, too costly, actually preventable. So in a way, we should really do action. And so moving on to the next issues is about the action. And I think we heard very clearly in the presentation how there have been progress in countries, including in terms of implementing programs, strategies at the national level. There's certainly a big attention also, which goes at international level. Patient safety also is, something that Germany has also put very much on the global agenda. So we're doing quite a lot at those national, international, global level. But there is a particular important dimensions which really has to do more with the implementation on the ground, and really what happened with frontline health professionals and workers and with patients. And I think, that is also an element which is particularly important if we want to make a difference in terms of hospital-acquired infections and more broadly about patient safety. So I was looking in preparing for this session at some of the data and information that we have related to patient safety and patient safety culture, for example. And some of them are, quite shocking as figures, but and those are based on a survey which has been done among the healthcare professionals. That's why I'm thinking the front line, it's really quite important, not just the, the global and national plans. Some 40% of the healthcare workers that we have reached out to in the survey, they say that their staffing levels are not appropriate for ensuring safety in healthcare facilities. More than 45%, or nearly half of the healthcare workers, also believe that it's important that patient care information is transferable across hospital units, and during shift and so forth, and this not happen enough, this sharing of the informations. And only half of healthcare workers thinks that their hospital management provides a work environment that is conducive to patient safety. So these issues of the culture. So I think there is a lot that perhaps we still need to do in terms of implementation on the ground, in terms of getting the health professionals equipped with the resources, with the environment, with the culture of also, if you want, no blame and openness, which is conducive to addressing any safety issues. The third point which I want to make is that obviously these efforts pay out. Michele has very much alluded to the return of investments of interventions. But I think there is another important point is that all these actions, whether they relate to a hospital-acquired infection, more broadly to patient safety, are affordable regardless of the level of income of the country that we are considering. So those are quite relatively cheap to implement interventions with huge high economic as well as health returns, which are affordable in all countries. And so in a way, we need to move on with the agenda and make sure that we ensure that both at the global and the national level, as well as in terms of the implementation in the front line, we improve this patient safety in a broad terms, not just in terms of hospital-acquired infections, but more generally. And I'll stop in there. But I think it's simple things that can be done. They have high returns. And in a way, we need to work with the front line very much to make sure that this is done.
Thank you very much. Interesting to have on the one side, it's too costly. This is really too costly. And on the other hand, this is really affordable. So those two really weigh each other up quite clearly. And thank you also for highlighting the patient safety culture behind it that we have to develop further. Professor Gastmeier, over to you. Germany is a pioneer country in IPC country with a standing program for a long time. In your opinion, what has been the determinant of the success of the German program? Over to you.
Yeah, thank you for inviting me to this session here. I'm in charge for infection control at Charité University Hospital, and I am also in charge for the National Reference Center for Surveillance of Nosocomial Infections. That means we have created this national surveillance system. And some months ago, we finished our last national prevalence study in the framework of the ECDC national prevalence studies. And our results this year was we have a prevalence of 3.6%. And our first national prevalence study was organized in 1993. That means about 20 years ago. And we had the same result, 3.5% 20 years ago. So this may sound disappointing, but you have to consider that the patients are much older now. They have more comorbidities. And so it seems to be a success. But of course, there's a lot of room for improvement. And I would like to come back to the requirements Benedetta mentioned. I also believe that education and training of healthcare workers is a very important point. And I think when considering the situation in Germany, it would be very good to set a national target, maybe to focus 1 year on surgical site infections, next year on bloodstream infections, and the year after maybe on spread of multi-resistant organism. And this would allow us to produce very good tools for education on a national level. That means really high quality tools, for instance, for hands-on training or for podcasts, massive open online courses. And I believe this could really bring us further. Thank you.
Great, thank you very much. Very interesting statistic there about the prevalence continuing. I assume that there are many more patients as well. So not only older patients, as you mentioned, but many more. And thanks also for highlighting the training of healthcare workers. I think certainly in the non-G7, in many other countries of the world, establishing a cadre of IPC professionals is really one of our main goals going forward. Turning to Professor Pulcini online, welcome to you. From the French IPC program, we know that you are very advanced in this program. In your mind, what have been the success factors in this advancement and what keeps it sustainable? Over to you.
Thank you for inviting me. Sorry for not being with you. I'm in Paris right now. And thank you for the question. I think that IPC targeting healthcare-associated infections is indeed quite advanced in France, thanks to a very long history of national plans and actions at all levels. IPC has been a priority for the French government for more than 30 years, and a facilitating system and many complementary actions were thus implemented in a stepwise manner. It was not done in 1 year or 2 years. It took lots of time. Among the success factors, I would like to mention first, motivated and well-organized IPC professionals. You were raising that point, with a very dynamic national IPC professional society. Second, the fact that all regions in France have had for many years a regional IPC center in charge of implementing an IPC strategy in the region in all settings, meaning hospitals, nursing homes, primary care, in line with the national policy. Third, that it is mandatory for all hospitals to have an IPC team, and we are now providing national funding to all regions to implement IPC teams in nursing homes. And last, Public Health France, our public health agency, is coordinating surveillance and prevention activities at national level in collaboration with designated IPC regional centers. So data for action and resources and tools are made available to IPC professionals, and sharing of good practices and innovative experiences is encouraged and facilitated. Of course, things are not perfect, and there is still lots of room for improvement. I believe that sustainable and sufficient funding of all these activities should be maintained, and that it is crucial to ensure that enough IPC professionals are available, which is not so easy. And making sure that all health professionals are regularly trained on IPC is also necessary, as raised by everybody on the panel. And it is also not so easy to achieve and to monitor, especially in France.
Great, thank you very much. Again, highlighting the importance of the motivated IPC professional cadre of people that really make this the center of their work. The other part that came through with Professor Gastmeier and yourself is the data or action needed, and really the surveillance that we need to set in place in all countries, really, to be able to follow up and to redirect the program as needed. I would like to open the floor to any questions in the audience. So if there's anybody that would like to ask the panel or indeed the speakers on their presentation any questions, now is the time to do so. We've got a roving microphone that can be handed to you. So both on the floor and on the internet, you're welcome to put out any questions. I'd also just point you to the publication that was mentioned. There are a few copies lying out in the room. So this is the publication that was mentioned by the two speakers at the beginning, addressing the burden of infections and antimicrobial resistance associated with healthcare by the OECD and WHO. Any questions from the room? The floor is open. Please, sir. If you could briefly introduce yourself.
Hi, my name is Masfin. I work for the International Rescue Committee, humanitarian organization. So when it comes to IPC, I mean, we work in low-income countries and conflict affected. And whenever there is outbreak, there is interest in IPC, like we have seen in Ebola or COVID, there's investment that goes and there is attention. But I think what we see from place to place is that it's very difficult to sustain the IPC practice beyond the outbreak phase. So it would be great to hear from the panelists, what's your advice in terms of, sustaining IPC practice beyond, the practice that we see during pandemics or an outbreak. So that is the kind of challenge that we see in many places. Thank you.
Thank you very much. Great question. Who would like to field the question? Professor Gastmeier.
Yeah, I would like to support also the comments from Celine. I think it's very important to establish a structure for infection control. And for instance, in Germany, we are in a very good position. Since 2013, we had a new law, and in this law was written that each hospital has to employ a certain number of infection control nurses and a certain number of physicians, at least if they are bigger hospitals. And since 2013, the hospitals are also compensated for sending this staff to training and also for employing this staff. And this was a big step. Before 2013, many hospitals had infection control nurses, but not enough. And only the biggest hospitals had infection control doctors. But since 2013, since we had this new law, it was a big improvement.
Okay, so that's a very interesting answer. So by regulating that sustainability is actually built into the system. Are the other, Professor Allegranzi, please, and then Dr. Colombo.
This is a very important question and something that we are asked very often. I think that first of all, we should really stop, pause, and think of the lessons learned from this pandemic. And I know this is an exercise that not many people want to do, but it's very important because I think we need to all go back in our mind and also stimulate our politicians to do so, to the images we all saw on TV or we lived personally as healthcare professionals of the totally overloaded health systems that in all countries, including high-income countries, we saw that. So I think, and also if you look at the two reports that we issued, there are data that WHO and OECD have modeled and issued for the moment in this report, but hopefully soon through a scientific publication, which, for example, show that if there had been capacity to rapidly increase the availability of personal protective equipment, combined with rapid scale up of training among frontline health workers, we could have avoided about 50% of infections among health workers globally. And we could have spared more than $7 billion worldwide based on these basic estimates in the first 6 months of the pandemic. So I think we really need to have the courage to stimulate ourselves and others to reflect on the lessons learned, because there are many. And the only thing that can be done is really to look at what needs to remain in place at the minimum, especially thinking of the situations you were mentioning, fragile countries, emergency, war situations, where it's particularly difficult. Honestly, there are many other priorities, but when an outbreak comes, it really blows up everything else, in addition to the daily constraints that are occurring. So I think that we really need to go back to the basics and enforce the basics to be present every day. So this is the point, I think. And as I said, all of us, I think we need to take a little bit of time and try to also document these lessons learned for all us not to forget.
Thank you. Dr. Colombo, any addition?
Yeah, no, just because obviously it's going to the point again of going back to the basic every day. I mean, the cost of inaction, the cost of not doing so far outweighs the cost of implementing those policies. And I think that needs to be, it's something probably that even those that deal with budgets and so forth in hospitals, in healthcare facilities more broadly can understand, you know, the cost, not just in terms of human life, but also in terms of healthcare expenditure, additional expenditures, and not to speak about obviously the indirect cost for lost productivity of the people affected and so forth, far outweighed the implementation cost of those strategies. And I think that's a very, very, very important point that can, can resonate. And this means that you not just implement the thing when you have moments of acute needs and then you forget about it. It's something that needs to be implemented on a daily basis. And I also go back to the issues of the importance of this culture of safety more broadly, because yes, you need to have trained professional in specifically on that, but more broadly it has to do with the culture also of openness, of reporting, of no blame, of really looking at when there is a problem that happens, trying to understand what were the causes of it, and having a more culture which is conducive to addressing the issues, understanding the root causes of the problems. I think it's really quite important for infection prevention and control, and more broadly for safety.
Thank you for that intervention. I see Professor Pulcini also wants to come in. Over to you.
Yes, maybe two ideas as suggestions. First, I think maybe IPC framed as a way to prevent, prepare, and response to a pandemic is maybe a good way to have some leverage in your country. And maybe second, to link healthcare-related IPC, as we are discussing right now, to a more broader approach of IPC targeting community-acquired infections is maybe also a way to move forward. That's what we are doing in France with our national strategy that is called Preventing Infections and Antibiotic Resistance, where we include both healthcare-related IPC, if I can say that, and also infection prevention and control targeting community-acquired infections.
Thank you for that intervention. Professor Hanan Balkri, over here.
Thank you very much. If you may allow me also just to add to the responses, just because I couldn't stay quiet a little bit on this. IPC is my background as well, but I think there are opportunities.
Could you just introduce, please?
Hanan Balkri, I'm a pediatrician, infectious disease, but also I'm the ADG for antimicrobial resistance at the WHO. And the sustainability of infection control, infection prevention and control in many of the mid-low income countries, there are several big opportunities that I hope that people in the room will be able to capitalize on based on their backgrounds. The first one is their engagement on health system strengthening, specifically for looking for national fundings and for the national and international funding opportunities, such as the Global Fund, Islamic Development Bank. Those opportunities, instead of looking at the IPC directed into siloed TB, HIV, malaria, can also be initiated within the health system strengthening, so that you're creating sustainable, long-lasting IPC programs in the countries that are funded by these international funding agencies that I mentioned, and there's probably more. That's one huge opportunity, because again, we do not want to use IPC to turn out fires. We want IPC to be there as a robust program. The other one is the negotiations of governments on the international binding agreement now on pandemic preparedness and response. So that is another opportunity that the language of AMR and IPC is there. And the third one is the fifth support for preparedness and for the global pandemic architecture. So there are opportunities without having the manpower and the mindset of robust, comprehensive IPC programs. It will continue to be small bits and pieces of responses. So I think that's maybe some opportunities also.
Thank you very much. I think that is very important. Just also pointing maybe to the process in WHO underway. We were instructed by member states to actually develop a strategy for IPC in WHO. And of course, the question on sustainability of IPC is very much in the center of that strategy. So that is really part of that. And we would encourage you, if you have the time, to actually get into a conversation with us on how that should be formulated. Are there any other questions in the room over there, please? The microphone is coming. Please introduce yourself.
Hi, my name is Simone Mancini from the Global Sepsis Alliance, and thank you very much for all the presentations. Very, very interesting. And I have a question, perhaps specifically to Mr. Cecchini. And first of all, I want to thank Mr. Zubel, and also actually that he made the link actually, in fact, with sepsis. And I'm delighted to see that also the relation with the AMR and healthcare associated infection and sepsis also stated in the report. And my question is, when you looked at the cost of, and I think you had a slide about the cost of AMR on a healthcare system, and does that include or have you looked specifically at the case that of course AMR develops as the report says as well, can develop in sepsis, and also of course you looked at the course that such infections, AMR related infections can have on a healthcare system. But do you also consider let's say the cost, the long-term cost, like beyond discharge? Because of course in the case of sepsis, for example, that I know, of course that can entail long-term sequelae and affect, of course, not only the healthcare system but the whole economy, because affect the people ability to contribute to the society as a whole. Thank you.
Thank you. Who would like to take that question?
Shall I start?
Yes, please.
And then I leave others. Well, your question is very right. In this report, the one that we presented today, we only looked at the cost for healthcare system. Including for sepsis, we know that antimicrobial resistant infections are more likely to have consequences. They have sequelae. They require more complex care, and this is what we took into consideration in our analysis. Then there are all what the economists call indirect costs. I don't like very much the definition of indirect because to me they are very direct from the disease. But there are things related to people stay away. In some countries, particularly those with poorer safety nets, this means that perhaps people cannot make a salary, make a gain for their household and their family. These costs are not included into this analysis. We know that they are significant. And also, we are, in a way, putting the basis for very long-term costs. Now, in this report, we only look at the G7 countries at high income, to be honest. But for those of you that were in this room this morning, there was a very interesting presentation from HME, and they showed that, for example, particularly in low and middle income countries, the vast majority of people that are affected are children. Children are really the future of the economy of a country because they are the human capital of this country. Your question also gives me the opportunity to let you all know that we are finalizing a new set of analysis that takes into account the impact of antimicrobial resistance on the broader economy. Broader economy in terms of workforce productivity, people that stay away, that have an infection, stay longer away from home, they contribute less to the economy, they consume less. So in the next report that you will see out at the beginning of next year for a much bigger number of countries, you'll see also the impact on the workforce productivity as well as on the GDP of countries for the next 30 years if AMR and infections continues to grow at the same pace that we have experienced in the recent past.
Thank you. Any other comments? Okay, one more question from the floor, please. Where's the microphone? Over there, please.
Thank you very much. My name is Andreas Berglöf. I represent WaterAid. So I would like to also follow up a little bit on Dr. Balki on the international investment. So my question is, how can we show that efforts to improve IPC in G7 countries also push for joint up investment in IPC and WASH services in least developing countries and with the existing financing mechanisms that are in place? Thanks.
Thank you. I think that's a great question. So looking further at the investment that is needed. So actually, I'm going to turn to OECD, to Dr. Colombo again, in terms of the investments needed. You've shown the cost effectiveness, you've shown the effectiveness of this intervention, but the questions remain. When the pandemic is gone, how do we sustain it? How do we actually make the investment go beyond the OECD? And where else do we have to invest? Is it only in prevention of AMR, hospital-acquired infection? Over to you.
Look, it's a big question because, the investment case, of course, what we can offer at the OECD is giving some of the tools to use in your arguments and discussion of why it's so important, it's so fundamental. It's not just, again, a matter of health, which is obviously the first most important things. But when you then talk to, in a context of tight budgets, of changing tides in terms of where the tension globally is going and so forth, and health is losing a little bit that spotlight in a way or another, you need to have arguments which are able to convince finance ministries and which are able to make a sound economic case. And so again, these costs of inaction, the fact that it's more costly, not to do nothing rather than to implement, these are things that needs to be pushed very much ahead. And these are the same arguments which are applicable to high-income countries, G7 countries, as well as to low middle-income countries. I mean, the cost of implementing those programs is really nothing relative to the cost of not doing it. And I think that's where I would. There are definitely more, perhaps, that can be done also in perhaps learning from successful experiences, including in G7, but not just in G7 countries. I mean, we have seen that even on some certain issues, they're not necessarily the top. I mean, I'm looking at you. They're the top performer on everything. So, perhaps we need to look a little bit more at why have some countries been a bit more successful, not just the implementation of the program, but even in making sure that you create that culture for implementing, for sustaining the investment and so forth. And so perhaps also going beyond what this report looks at in terms of G7 countries. But we'll probably, stop in there. To me, making the cases and economic issues is going to the decision makers, is also going at the level of, people working on the ground, the frontline workers themselves, and, making sure that their voice, can also very much be moved up and heard, and not to speak about the patients who are the ones that suffer more directly from these issues.
So I think looking a little bit beyond the scope of the G7 only here, of course, in the global perspective, that investment is very important. I myself come from South Africa, as you probably can hear from the accent. So how do we convince South Africa? How do we convince Kenya? How do we convince Peru to invest in IPC further? Yes, please.
So thank you, Rudy, and thanks also to the colleague who asked this question originally from WaterAid. I think that the most important is to help countries to understand how to gather local data and how to use them. And in these regards, I would say high-income countries and, for example, G7 countries, as you know, have, as we heard today, have a long-standing experience in collecting data and using them. So, and they also learn from mistakes, I suppose. So I think that from the global level, from the country level, where we have more experience in doing this, we need to help. Need to help to collect basic data with a sufficient level of quality, and especially help them to learn to target primary needs instead of aiming to do many things. But local data are essential, and including data regarding the cost. So at WHO, given that now we have the mandate to develop a global strategy, which will then be hopefully adopted by countries to develop their own national strategy for infection prevention and control, we are reflecting and working actually with OECD as well on how to help countries to cost these plans. And there are some tools which are already available, for example, to cost national action plans for AMR, a tool provided by WHO. There is another tool that WHO developed with UNICEF to cost national efforts to improve hand hygiene. So I think that some tools exist and probably they need to be promoted more. But especially we need to help in a practical way about how to collect data and how to use data. And this is, I have to say, a problem which is widespread. I know, and I visited many high-income countries where they do have systems for collection of data, but then the feedback and the translation into action of this data in a timely manner is not optimal yet. So it is really important to be able to collect essential data and then interpret them, and they make them usable at the front line or at the managerial level in healthcare facility rapidly. so that there is an impact and we can decide on what needs to be prioritized from the intervention point of view. So this is something I think we can do for high-income countries as well, as I said, but especially also to support the work and the progress in countries which have less developed programs and have, unfortunately, yet less expertise.
Thank you. Very good point. Professor Pulcini, you have your hand up. Please, your comment.
Yes. Just again, a suggestion that may depend on the country, but often to raise the level of priority on the political agenda, patient association advocacy is very powerful. And that was the case in France for nosocomial infections in the 90s, where the patients' associations clearly changed the political agenda regarding IPC. So maybe that can be also a way to push forward the topic in some countries.
Thank you. Very good point. Let me turn back to Professor Gastmeier, referring back to your comments about surveillance and training. It occurs to me that those are areas that countries can actually learn further from you. And I wonder if you can expand a little bit. Even in the OECD, I'm sure there are improvements to be made, but even beyond that. Would you like to take that up, please?
Yeah, I think you should have in mind that improvement takes time. And it's also necessary to improve the surveillance system again and again. It's not enough to create a surveillance system and then it's enough and you can wait what happens. You have to improve the system again and again. For instance, today we try to introduce automated surveillance in order to shorten the time for surveillance. I think this is a very important point, but the most important point, Benedetta mentioned this, is the translation of the data into action. And this means the interpretation of the data is very important. And also to decide what should be done now. That means the analysis of surveillance data and the introduction of interventions. This is the most important point. And finally, of course, you have to evaluate if this was really necessary and useful. And I think it's not only enough to create such a national surveillance system, it's also important to monitor processes. For instance, hand hygiene, observation of hand hygiene. This is meanwhile introduced in many countries. And I think WHO did a very good job in this field and created this worldwide system to improve national, to observe hand hygiene and to improve compliance. But we should also do something to evaluate dressing changes or insertion of catheters or monitoring other processes. I think this is a further step and we should deal with this monitoring in the future.
Mm-hmm. And the training component. So you said you were moving much more also in the training of the...
Yeah, but training enough is not enough. You have to also to monitor what the people are doing.
Clearly, yep. Okay, so again, I'll open the floor to some questions. I see two hands over here, the gentleman.
Thank you very much. So I'm Bento Zogle Tehonge. I'm from the Ministry of Health, Liberia, responsible for the RAMCAT. That is family health, that's responsible for reproductive, maternal, newborn, child, adolescent health. I want to say thank you so much for the presenters. And I'm very, very interested in the fact that advocacy is the way to go. Most of the time from our side of the world, the envelope, and then the government apparatus to serve. We have been doing advocacy. I just wanted to know whether the reports that have been developed that we have today, whether one of the tools alongside that is an advocacy tool, just to see how we restructure our advocacy strategy. Maybe that will help us to be able to actually inform and lobby with the parliament, which is actually the system in my country that divides the national cake. So my advocacy from this room will be to help us with that very important tool. Thank you.
Thank you. Very good point. So how do these documents, this information, how does that translate into political advocacy?
Yeah, very briefly, first of all, next year we hope to actually develop a more a glossy version of these reports with some information packaged in a way that can be used for advocacy. So again, making the business case for IPC, but maybe producing a shorter version of these documents with the key messages that can be used to convince politicians, for example. The second point is, as I was mentioning earlier, I think that as WHO, and certainly I would like also to join hands with OECD once again, I think we need to help countries to develop their own business case. And this is what I was mentioning earlier, trying to help with additional tools to develop, to cost the interventions that are needed at the country level. This is extremely difficult, but we will try. We have a project together to work towards this. So these are the main things that, and the last one, which I think can be taken up by anyone, including you, of course, especially in the position you are, is that the resolution and the future global strategy, these are documents that can be taken up by anyone and go to your government or engage, for example, as it was said, civil society advocacy groups, patient engagement, and patient representative organizations, and all together from this end as well, take up these documents and make your ministries accountable, because they have signed those documents. They have adopted those documents officially. So now there is a need for showing progress over time. And it takes time, but in 5 years, we will get there maybe. 10 years ago, we were far from where we are in infection prevention and control. So progress is happening.
Great, thank you. Michaela, very briefly, please.
Sorry, I asked first. Quickly, I think that the business case, particularly when carried out jointly by OECD and WHO, are an exceptionally strong vehicle tool that ministries, advocacy group can use. And I'll give you a quick example of a completely different field, promotion of policies to tackle non-communicable diseases. In Africa, a few years ago, we joined forces with WHO to help South Africa implement taxation of sugar and sweetened beverages. He started with usual suspects strongly against it and a very difficult political situation. With WHO, we created a business case. We spoke to the parliament. We spoke to the Ministry of Health. We spoke to the Treasury. I think the two organizations are very complementary when it comes to these things. If WHO goes to speak to a treasury, sometimes they may hear, oh yeah, but you only care about health. There is also the economy behind it and so on. And that's why OECD complements so well this organization. So that's an extremely powerful tool that I think we could explore more also in this field. But I would also like to take this opportunity to respond to another of the issues raised. Data to make action, very important, agree. Training, super important. Let's also consider the incentives that I don't think have been mentioned sufficiently until now. Positive and negative incentive. Most of the things that are done at the very ground level in hospital are dictated by what is available, what is current practice, what people around you are doing, and they know because I started my career as a medical doctor working in an hospital. And, I remember when I had to wash hands between two patients and so on and so forth. So, linking the positive incentive to good practice, and at the same time, making sure that the negative incentive to the good practice do not hinder our action I think, is a fundamental thing to success at the ground level.
Okay, we are coming to the end of our session. Unfortunately, time is running, so I apologize to the two audience members that want to speak. In fact, I'm going to ask the three panel members if you would like to say a final word in summary, maybe starting off with Dr. Colombo.
Well, I think I will reiterate the points. I mean, it's in a way, we know what are the tools to make a difference. We know that they're cost-effective measures. We just need to do it, and perhaps use also the material that we have produced jointly with WHO and OECD to try to make your case, both in terms of the politicians, I would say, also in terms of the managers, whether they're hospital managers, whether they're long-term care facilities managers, and so forth. So in a way, we have the tool, and we'll be very delighted to support efforts in the implementation from our side.
Thank you so much. Professor Kasmai.
My final recommendation goes in the same direction. Don't forget the hospital director. I think it's important to train the hospital directors that IPC is a very important point. They should know how to interpret surveillance data. They should understand how important it is to stop an outbreak immediately in order to prevent further spread. And they also should support their role models in the hospital. This is also a very important point.
Thank you. And Professor Pulcini, final word.
Yes, I think I would say that progress is possible and is necessary, and that we need to have courage and to keep on. But I'm sure that will be really better in 5 years, as Benedetta was saying.
Thank you so much. So big hand to the three panelists. Thank you so much. We really have run out of time, but I'm going to ask Dr. Naira really for very briefly, we have 3 minutes really, if you can just summarize your presentation quickly. Over to you.
3 minutes. First of all, apologies for leaving. It was a kind of emergency by the Director General, so you cannot say no. But here, I'm very pleased that I'm here and you give me this opportunity. 3 minutes. One, you heard the diagnosis. We have huge problems with infection prevention and control at the hospital level. We have infections. You saw the maps. We have a huge problem with antimicrobial resistance. Let's look at the causes of all of that. One of the biggest, the most important cause of having those infections is because half of the world population, half of those healthcare facilities, they don't have access to basic sanitation. How do you want to sort it out, the problem of pandemic preparedness, of infection control, of antimicrobial resistance, if our healthcare facilities do not have wash, they don't have sanitation, the possibility of washing their hands or water? So I think we can provide this pillar of investing, the importance of investing on water and sanitation services in order to control all of the infections that we can prevent and the spreading of the antimicrobial resistance. Most of the poor countries in their situation, in the 46 low-income countries, 8 every 10, they don't have sanitation at all. So even during the pandemic, when we were recommending people so strongly, wash your hands, half of the world population cannot wash their hands. So my final comment, Rudy, if you allow me, will be, if you have a healthcare facility or a hospital and a director without wash services, without water and sanitation and hygiene, don't call it a healthcare facility or a hospital, call it something else, but not a healthcare facility. Because if you don't have the basic for hygiene, you cannot go to get treatment or care. If the person who will take care of you cannot wash their hands. So infection prevention and control started with the basic, and we still need to do a big effort to provide the basic. It will take $6 to $9 billion between now and 2030 to make sure that everybody will have access to sanitation and water. Maybe we should invest on that, and then things will change. Thank you very much.
Thank you, Dr. Naira, for that summary. I think very important grounding also for this discussion. With that, let me hand back to Mr. Zubel for the final word. Thank you.
Thank you very much, Dr. Eggers, and I'm aware of the time. So let me be very brief, but I would not want to miss to thank to WHO and OECD for presenting and launching the policy brief on IPC. And also great thanks to all the speakers and the panelists and to the delegates from countries for this really interesting and compelling discussion. And lastly, thank you, Dr. Eggers, for your great moderation throughout the session today, and to the entire audience for your interest and for being with us today in this really important session. I believe that that our discussion made it very clear that the topic of IPC needs much more attention, and not only in the context of healthcare-associated infections and AMR. When I heard what the panelists said and what the audience, the question they asked, I heard about training and education of healthcare workforce. I was personally struck by the investment case, the return on investment case. We heard about positive incentives to good practices. We heard about many more other issues. But if we want to sum it up, I think it's fair to say that at all levels, actually at the policy level, the healthcare facility level, and at the individual level, we need to bundle all the efforts, and the G7 can lead in this regard. So a global effort is necessary to reach the aim to provide good quality, affordable and timely healthcare to all. And the G7 are committed to lead by example and also share their experiences. With this, I would like to leave you and thank you again, and wish all of you a very successful and hopefully great final session, which starts, if I'm not mistaken, at 4 o'clock this afternoon. And thank you very much.